Great. Thank you, Dr. Carnaby. Hi everyone. Thank you so much for joining us. Today we have Dr. Giselle Carnaby with us. It's truly an honor to have you, Dr. C, that's what we all call her, um, with us. She is an internationally recognized leader in dysphagia research and rehabilitation. Her work has been significantly shaped how we assess and treat swallowing disorders across clinical settings. Dr. Carnaby has been heavily involved with functional oral intake scale. We all use that during our bedside. It's a widely used tool that helps clinicians track a patient's functional oral intake scale. And also, as we all know, the treatment, McNeil Dysphagia Therapy Program, which is an evidence-based, exercise-driven approach that focuses on improving swallowing to neuroplasticity and through the intensity. Her contribution have truly helped bridge the gap between the research and the real world clinical practice. And we are so excited to learn from her today. Welcome, Dr. Carnaby. We're so grateful to have you here.
Thank you for inviting me.
Thank you. Let's see. We are going to, I'll have like 5 questions for you, and you're more than welcome to add more. But this is more for, and also, sorry, I should have started with that. It's National Speech, Language, and Hearing Month. So, so happy speech month. And yes, we need to, have more awareness, create presence of what speech pathologists do, because most of the times they're like, my speech is good, but we also heavily work with dysphagia and patients with dysphagia. So this is basically is one of those meetings that I wanted to set up with you. And also you've been my committee, you've been on my committee for my research, my dissertation. So I was like, no, I have to have Dr. C for this to begin with as a head start.
Okay.
Thank you. Okay, so I'm going to start with the first question. So, Dr. C, what initially drew you to focus on dysphagia and swallowing rehabilitation? And the question I'm asking this is primarily because for all clinicians who've done the certification of MDTP, we all see it's so heavily clinical based. And the best part, what I like about that is that even for the newer clinicians who are just trying to get into working with patients, it's such a structured approach. Unless you're a clinician, you can never know what to work with it and how the structure works.
Sure. So a lot of people don't realize that I didn't just go through my degrees and get a PhD. So I went through my bachelor's degree in Australia and went straight into the clinic. And I worked in the clinic and worked there for over about 12 years in total, before going back to school. So I'm a non-traditional student. So I like to think of myself as a clinician scientist. And what I mean by that is all of the work that I've done in my career has been focused on questions that have been derived from the clinic to help patients and clinicians be more effective in what they do. The reason that began, and my journey's been a long one, I started working in a stroke rehabilitation unit, a comprehensive stroke unit, started in the acute care and moved to the rehabilitation. And that drove my inquiry about why don't people think we can do anything? Because back then, when I started, the question and the statement I used to get a lot from the neurologists were, well, you just don't do anything. So, you come by, you assess, you might change your diet, but you really don't do anything. And so that kind of got me all stirred up as a youngster. And I wanted to find out and to do research, even though I wasn't trained in research. I want to do research to try and work out what we actually do and how we can improve that perception. And so when I started, the first thing I was asked was, well, how are you going to measure that? So what is dysphagia and how are you going to measure it? And at that time, all we had in the literature were checklists. We're talking about the middle of like 1986, 87. is when I sort of started asking those questions. And so the neurologists I work with said, well, you're going to have to come up with some kind of measurement systems if you're going to measure this phenomena and you're going to then intervene with this phenomena. And we didn't have anything. Logoman in 1983 had come out with video fluoroscopy, and she had some observationally based statements about different things that happened in swallowing, but there was no real measurement, what we call psychometric measurements out there. And so I embarked, unfortunately, on a long 14-year experience in creating some tools that didn't exist before that. One of those tools that you talked about, the functional oral intake scale, came out when I arrived in America. So I worked and did my PhD in Australia, and then
Mhm.
after I finished that, in that work, I developed the MASA, and then after that, came out to America and started working with a very experienced team at the University of Florida who
Mm.
were all clinicians but were not scientists. And
Okay.
so my training had been in Masters of Public Health and a PhD in Public Health. Both of those advanced degrees were in biostatistics and epidemiology. So I truly was a clinician scientist when I moved out to the US. So when I got and joined the team in Florida, which include Michael Grower, Michael Crary, Jay Rosenbeck, there was a bunch of them right there. Leslie Gonzalez Rothy,
Mm.
um, also Chris Sapienza. So we were a real elite dysphagia respiratory team that were out there. I started applying my knowledge base to their concepts. And so they had conceptualized a measure of functional eating at that stage, but it was not in a workable form. And so you couldn't really use it because there were too many levels and they didn't make sense and they didn't flow together properly, and no one had validated the tool. So
Mm.
I put my biostatistical magic to it, and we, as a team, created the functional oral intake scale. It was only really conceptualized to measure where a patient is in their eating at one particular point in time. So this measure doesn't measure what the speech pathologist thinks you should be eating. It measures what they are eating right here and then. And that's probably one of the biggest misconceptions with the voice. So when you have this 7 point scale and it starts with not eating anything at all to eating anything you want, anytime, anywhere, what we're asking is, what is this patient actually eating? Not what you prescribed. What are they actually eating right
Thanks.
here and now? And over the years, we have initially validated that in a stroke model, and it's been validated and revalidated in different populations. And we looked at whether it could be shortened or reduced, and we found out no, it's actually its perfect length right now in terms of its validity and psychometric stability. And then this particular scale is so simple that it's well easily translated to other languages and to be used worldwide. So that's why it's taken on a life of its own and why it's been so well adopted across the world. Um, and it's helpful because it lets the clinician know exactly where that patient is in their oral intake and how much of it is actually going toward their consumption nutrition.
So true.
And quite often, that voice level that they're assigned initially is suboptimal. So it helps guide following evaluation where that patient moves to. So not only is it a measure at one point in time, it can actually show change across time. So it's a valuable measure in showing that what you did as a speech pathologist in working with this patient improved that patient's intake over time. So it's also an outcomes measure.
That's amazing. Yeah, because we all know it's so important for patients to have the amount because you would just like you recommend a diet, but then more often than not, the biggest problem is patient is not eating. There's no way to measure it, but this scale tells you the levels, and I've used
Yeah,
it.
so just because the patient's been told what diet to be on doesn't mean that's what they consume.
They're getting intakes, yes, and then
And
also sorry, go
and
ahead.
you know, and families bring things in and they don't take what's on the bedside and they take the man next to them, take their consume their food, and all sorts of crazy stuff goes on.
Actually,
And the scale was simply to reflect that, what's actually going in their mouth and what is functional. And that's why it's called a functional oral intake scale.
it's wonderful. I absolutely love it, and we use it all the
And of
time.
course, there's an app for it now. So that makes it easy. If you're having trouble making those decisions, there's an online app you can get out of the Apple App Store to help you.
Okay, thanks.
It's gone full circle.
It comes full circle. Indeed, definitely it does. Thank you. All right. So with that being said, I'll move on to my next question. We talked a lot about the FOIS, so I'm gonna like hold off onto it, and then I'm gonna jump onto MDTP. For clinicians newer to dysphagia, how would you explain MDTP in a simple, practical way for them?
So this is complicated because I have to simplify everything down,
All
right?
right.
So, and I'm verbose, so it's hard for me. Um, the best treatment for swallowing is swallowing itself. MDTP focuses on that at its core. So we wanted to come up with a way to treat patients that had a number of intuitive aspects to it. One of the biggest things we have trouble with when we give patients maneuvers, compensations, things like that, is you never really know if they're doing them. And then you don't know how often they're doing them or how persistent they are with them. And we had a lot of things that we offered originally before MDTP that we just didn't think were self-motivating. And we had some data that suggested they weren't motivating at all. And only those patients that really, really went in and worked got benefit from them. And so
Mm,
MDTP was put together using exercise science and neuroplasticity data from neurology and from brain studies. And it was put together basically to become a program that is self-rewarding. So it functions very much on the vagal gut-brain relationship. So people don't hear me talk about that too much because I don't want to get too complicated on people in terms of neurophysiological models, but this is really a vagal gut-brain reward system. So when we eat and we like eating and we enjoy what we're doing, we get endorphin rush and we get dopamine, and it reinforces the behavior. So, underlying this treatment is this concept that if you can get a person eating materials they enjoy, they will also get rewarded for it and it will promote the behavior continuing. So, that's one of the concepts underlying MDTP. The other concepts are that in order to rehabilitate a swallow that is impaired or what I call deconditioned, for a lot of our patients, it's not impaired so much as it's deconditioned. Before you become fast and coordinated, because we all know that normal swallowing is very quick within a second, and it's fast and it's coordinated. And abnormal swallowing tends to be less coordinated and less efficient. So, in order to become coordinated and efficient, you need to have a certain level of strength. And a lot of our patients that we see have weakness as an underlying facet of the disorder. It's not the total disorder. They've got incoordination, they've got breathing organization problems, they may have a bunch of other things. But in order to rehabilitate those, what I call higher level concepts, you need to first develop the little bit of strength and then gradually modify the behavior to move it back in line with normal swallowing. Now, that
mm,
doesn't mean everybody who gets MDTP comes out the end with a normal swallow. They do not. But we put their feet on the right path in terms of timing, coordination, and strength gains to be able to support those timing and coordination improvements. And we have a lot of data, 14, 16 years worth of data captured in research and in clinical data that supports the efficiency of this technique. And it didn't just happen overnight. It took
for sure.
years and years to develop and to test various aspects of it. And so, what you see when you learn MDTP now is you learn the final package that resulted from all of that trial and error that went on early on. And so now it's encapsulated in a very structured technique and in such a hierarchy that the clinician can evaluate the patient based on their severity and their impairment, plug them in at different levels on that tool, and
Right.
then keep working the system to build the strength and build the timing and the coordination along with it. So it's a progressive approach to treatment, which is not like you've seen before, because
No.
a lot of the other treatments are here, let me give you this device, do a bunch of reps on this device, let's see how you go. It's not a progressive skill development tool. And that's the difference between what we offer in MDTP and what is offered elsewhere. Now, of course, we've been out there for a long time. So over time, a lot of our conceptual basis and a lot of our sections of our tool and our technique have been bastardized by others out there and imported into what they do. So, for example, if you've ever heard of the boot camp approach from MDTP, from MD Anderson, they've included MDTP in that. So that's part of that. So there are other groups that have taken bits and pieces from what we've put out there and they've added it into their therapeutic regimens. And so in some ways, I think we're the grandparents of a new wave of intervention that's out in the ether for speech pathology. And that's kind of a good thing, you know. Replication is actually it's good to have that and it's good to see the field moving ahead from that. So I'm all for it.
That's amazing. Thank you. You know what? I am going to, sorry about that. Technology. Okay. All right. My third question is very interesting, and I also wanted to get more answers to this because I know, the MDTP is so heavily based on this concept. There's a lot of talk about the intensity and neuroplasticity. How should SLPs realistically apply this in everyday practice?
So, I'm not quite sure what you mean in that these are conceptual ideas of how the body adjusts and the brain adjusts to different input or stimuli. Okay, so depending on where I usually look at this in a different model than you probably haven't heard too much. Some people that heard me might already know the model, but basically you need to look at person, you need to look at task, and you need to look at environment. So when you look at a person, a subject, a patient, okay, you have to first identify where is my patient at in terms of their learning ability for complex behavioral movement. Sorry about the dogs barking.
Okay.
Um, so we learn in different levels of expertise. So some people are at a novice level where they're at what we call trial and error learners. So their ability to respond to a stimulus, move their body parts, move their respective muscles in different ways, are really incoordinated. They're very basic. They're very delayed. They're very trial and error. And that's a novice learner. So given a new environmental stimuli or a task challenge, their response to it is likely to be inefficient. It's likely to be, as I said, trial and error. It's likely to be farther from the target of accuracy than you want it to be. So you evaluate patients in this regard to begin with. What is the person able to do in terms of their learning ability? Are they novice? Are they in the middle? Are they moderate? Are they advanced intuitive learner? You know, can they just respond to a task very rapidly, dependent on the level of difficulty of the task? So that next level you have to look at is task. What am I asking them to do? Is the task very just simple model response, or is it a complicated task with multiple components to it? Does it require decision making in the task in order to hit the target? Does it require vestibular balance? Does it require more cerebellar input to get to that movement? Does it require more frontal lobe evaluation from like an increased executive functioning component to get to that task level? You have to look at the task you're asking the patient to do, and then you have to think about, all right, say my patients at the lowest end of this can really only just mimic what movement I provide and mimic not particularly well, then I know that I have to scaffold the task more for that patient to be able to get there. Is my task going to challenge their strength of the system? Is it going to challenge the coordination of the system in terms of speed? Is it going to challenge both strength and speed in terms of coordination. Like, what is the task asking the person to do? For example, if I'm having somebody swallow a puree bolus that I know they have managed before, but when they do it slowly and there's a lot of residue, and there might be multiple swallows involved in just simply moving that puree through the system. I can tell you that that particular task is a lower level challenge for that person, but I have to make sure they have enough strength to be able to at least squeeze the material and create a pressure change in the swallow system. Then I have to be able to be sure they understand what I mean by hold position and push that material down. So I'm leveraging their learning ability. I'm leveraging what the task is asking them to do, how simple it is compared to other things. And then the last thing is the environment. So, if the patient is in an environment that does not challenge their cognitive processing, if they're in an environment that has a lot of support and scaffolding and modeling involved in it, if they have an environment where there's intrinsic clues that they can go by to help them. For example, maybe they're strapped up to an SEMG machine. Maybe they are able to follow a trace, so they're getting more visual scaffolding and support for the task. These things will change how I approach that patient and what the next level of challenge I give them is. So you're hearing a lot of the similar things that I was talking about with MDTP in what I'm saying, but you should always first look at the person, look at the
Yes.
task, and look at the environment that you're placing them in. And then those are the three components that you can alter. So as you move through treatment, you can alter that person's level of ability in learning by giving them more learning opportunities, by
Yes.
making things a little more complicated, by making things a little more challenging in terms of task. I can ask for multiple repetitions of a task. I can ask for increasing speed of a task. I can ask for increasing weight or volume of a task. I can make those tasks more difficult, but if you go too far and jump up too high too quick in a novice learner, they're not going to work. You have to make sure it matches where your patient is at. Same
Right.
thing with environment. I can make the environment more challenge. I can take them from a quiet therapy room to a complicated, noisy cafeteria. Or I could add in less direction. So they've got to follow more intrinsic, internally driven direction. I can take away the verbal prompt. Come on, swallow again, swallow again. I can take that prompt away. I can change the environment by changing the consistency or the stimuli that I give them. I can take away the SEMG machine, or I can turn it around, leave it strapped on so they get less visual support. So I can change every aspect of that to meet my patient.
Yes.
These are the things that challenge neuroplastic principle. These are the things that, in a very practical manner, that help you advance your patient. And that's
Absolutely.
without taking an MDTP course. That's just knowing that these are the things that you can modify: person, task, environment.
Absolutely. And the best part about that is it can be used across the board, regardless of the severity of dysphagia, depending on the patient's needs. It makes patients more independent. So that's the
And so it's
beauty.
something
It sounds fantastic.
you can also give back to the family working with the patient. I mean, you're not going to have the family advance them, but you can certainly have them work on the same task in the same way with the same environment that you do. So there's constant reinforcement of what they've learned. And
Right.
one of the issues we often see is people not being trained to think that way from the get-go. So they don't get this kind of input in graduate training. So when they get out there, they're kind of floundering around going, well, I don't know what to change, when to change it, and how to change it. And it's
How
one
to
of the reasons we came up with MDTP, is to try and make that a little more structured for people so they didn't have to flounder. And when you flounder,
absolutely.
the patient fails.
Patients.
And when the patient fails, they can get disheartened and they can stop trying. So, knowing a little bit more about how to embed these concepts of neuroplasticity, of intensity, of all of these concepts that are out in the literature, because a lot of literature on theory and very little on practical approach.
Practical. Beautifully said. You answered my next question because that's basically what I got so drawn into MDTP because it's the actual practical ways of utilizing it at bedside, regardless of, as I mentioned, the type of dysphagia, the severity, but it can be used across the board in all type of patients, and they get the benefits and they feel that they are doing things in terms of
And I mean,
how it's structured.
the ultimate goal of MDTP and a structured approach like that is to make the patient their own therapist. Sorry, guys,
Therapist.
I'm getting rid of you. Um, is to if for those patients who are capable, and not everybody's going to be, because you've got patients with dementia and other cognitive impairments that aren't ever going to get there. But in general, for a lot of our patients, even very severe stroke patients, you'd be surprised how many really severe patients I've had success with, is getting them and their family to support the ideas and support the progress to the point where they become their own therapist
And the clinicians.
and they
Yes.
learn how to do it themselves.
And they can carry it over. That is
Hmm.
absolutely true. Yeah. Okay, I'm going to switch this question as we already
That's okay.
talked about that. We're going to talk about spontaneous swallowing frequency. It's one of my other favorite topics. It totally, completely relates to the practical side of how you could use it. Yeah, if you could tell me more about how you really got fascinated with this concept.
So this came out of Swallowing Fixes Swallowing, okay? Years and years
Okay.
ago. All right. We just need people to swallow more. All right.
Yes.
Um, and that's kind of the discussion that went on before we got into this whole idea. And so one of the questions we challenged ourselves with is, well, okay, we all know we swallow our own saliva without thinking about it. How often do we do that? And this was way back when we first started. And we didn't have good measurement techniques for that either to work out how often do people spontaneously swallow their saliva when they're not thinking about it. So I'm not talking about what you do when you eat. I'm talking about what you do outside of eating. Okay, so
Mhm.
when you sleep, you swallow. When you're awake and watching the TV and not focusing on what anything, you swallow. And does that rate change when you're injured? When your system is injured. So, is it a measure of the integrity of the neural system controlling swallow clearance? So, the spontaneous swallowing that we do is there to clear away residue from the pharynx, to keep the airway clean, to bathe the tissues in pH neutral substances, so to fight off oral problems with oral over proliferation of oral contaminants and to help the system think of it like oil in the car to keep it clicking over. So, it's a really vital system. We know it's intricately tied to our brainstem. We know that brainstem responses like breathing are very similar to it. It responds to different stimuli. So we know that if you eat a meal, for example, you'll start swallowing spontaneously more rapidly after the meal. We know that if you're really have a lot of reflux, you will also swallow more rapidly. Your spontaneous swallow rate will go up. It has an emotional component to it because we swap between conscious swallowing and non-conscious swallowing. So it very quickly, if I stimulate you, will pop into conscious swallowing versus non-conscious swallowing, which is what we're measuring in spontaneous swallow frequency. So we know that there are some things we need to be cautious of when we measure it, but we also now have a lot of data that shows that the rate of spontaneous swallowing is a direct reflection of the integrity of the system. So patients with dysphagia swallow a lot less than normal healthy controls the same age and same gender. We don't believe there's a gender marker between spontaneous swallowing, but we do think there might be a diurnal marker between
Mhm.
spontaneous swallowing. We're researching that right at the moment. But the rate of spontaneous swallowing can indicate how often the system is being activated. And by activated, I mean how often those muscles are being used. And this is really interesting because we've just finished some work in Parkinson's, for example, that showed that Parkinson's patients use their spontaneous swallowing system at a rate way lower than even stroke
And
patients. So it's
Right.
a really, really low rate. And one of the reasons is this lack of dopamine that is the dopamine levels that are going down in the system for Parkinson's. It's not the only reason, but it's one of the reasons that that vagal gut brain relationship is modified and you see less spontaneous swallowing. Now, what that means, if you add it all up, and we've recently done this, is to show that on average, you probably swallow, including meals through a day, close to 3,000 odd times a day. A Parkinson's patient will swallow around 700 times,
Wow.
significantly less. So those
Us.
muscles get significantly less activation. So do stroke patients who are dysphagic. Significantly less movement in the muscles because they're not spontaneously swallowing all the time. Those muscles become deconditioned more rapidly than healthy normals. And so this is why this metric is useful. It can tell us, is the system functioning below age norms? Is the system deconditioned? Does the system respond to treatment that increases the conditioning of the muscle system and increases the stimuli and creates more swallowing? One of the things we also know from our research is that when we activate the system more through therapy, and this is your work, Sanal, part
Yes.
of your work, showed that this rate goes up and it stays up. So once you start working the system, you can wind the clock back up and the
Absolutely.
spontaneous swallow system can come back online. Now, how long that lasts for, we don't know yet because we've only got a small amount of work showing us how long it stays stable for. But if you pair this with feeding, we know that the rate increases post feeding. So if you compare it with therapy that increases feeding, the likelihood that those muscles will continue to remain well conditioned is higher.
Absolutely. Yes. That was beautifully explained, and I love that.
So that's how it ties into treatment. So we can use this rate both as a marker or a screener for
Beautiful.
swallowing issues, dysphagia, and we can use it as an outcome measure to show change across time and whether you need to give more stimuli and whether you need to do more therapy.
Yes. Yeah. That it's also an objective measure for clinicians also. So you can kind of rate it in terms of the diet you're introducing, you're going to advance it, and then
So
it
for
kind of
those
like,
that don't know, we measure this through a microphone placed on the neck and it makes a recording of swallow sounds and you count the number of swallows in a period of time. Then that's how we get the rate. And so it's very simple. It's language independent. You can put it on really severe patients. You can even put it on comatose patients. So it can tell you a lot of information with very little input from the patient themselves. And like I said, language independent, very simple. It's another one of those worldwide adoptable techniques.
yes, wonderful. I was going to add all that. Yes, absolutely. So, it can be used with all different kind of patients. It can be,
Doesn't
like it's
require cognition.
doesn't require cognition, and
Mm-mm.
also doesn't require a lot of training for clinicians also, because you can easily use it, and it's pretty handy, like mentioned, like how MASA or FOIS or MD, you can just kind of do it at bedside, and it's easy to use.
Yeah.
And I would categorize that as more like an objective, evidence-based approach
Hmm.
that you're using, because we are,
And
dysphagia
so
research.
one of the things we're doing right now is we're measuring this rate in progressive neurological diseases because we think it could be a early warning sign that someone needs more input from an SLP. And so we're looking at this particular rate and we're looking at how it changes across time in controls and treated patients.
Great. Amazing. Yeah, I know you've been working with with Parkinson's patients
Hmm.
for it. Wonderful. Thank you, Dr. Carnaby. It was
It's
such a
okay.
pleasure to have
Lovely
you.
talking with you.
Thank you. Thank you. I am.